Okay. So welcome to this NCICT symposium, and it's a great privilege to have Michelle Yong speaking. Michelle is an ID physician at Peter Mac and the Royal Melbourne Hospital, who completed a PhD in CMV immune monitoring and has continued her postdoctoral work in CMV management. So we're going to hear an update on CMV today from Michelle. Thanks, Michelle.
Okay, thank you. Thank you so much, Monica and NCIC, for the invitation to speak. I'm just going to share my slides now, and hopefully you can all see that. Can I just get a brief? Okay, that's all good. It's a pleasure to speak here, and I'm going to give a brief talk about one of my favourite topics, and that's the new developments in managing CMV in transplant recipients. My slides aren't moving. Yep. So CMV remains a challenging virus, and I'm just going to give a very broad overview, really aimed at clinicians or interested audience who may or may not deal so intimately with it, looking at the evolving concepts in our understanding of CMV over the years, concentrating a bit on the prevention and treatment of CMV and in the armamentarium drugs that we have, briefly touching on antiviral stewardship, and then therapies related to immune response, and concluding by our unmet needs. So to begin with, CMV as a virus is one of the largest viruses of the beta human herpes virus type 5 of a double-stranded DNA, and it sits in the family of other herpes viruses such as HHV6, HSV, and EBV. It's one of the largest viruses around, with a genome of greater than 200 open reading frames, with a tegumon layer consistent of antigens such as and proteins such as PP65, PP150, and glycoproteins. And transmission of CMV is via infected saliva predominantly, but also through mother to child transmission through placenta, and also in the early years breastfeeding. It's also transmitted through transplantation, which I'll concentrate on today. And the thing to note about CMV, and I'm always reminded of, is although most people are asymptomatic, it's the lifelong latency and reactivation of these viruses, and that they remain really dormant in our mononuclear cells, and there really is no cure for this at this stage. So as a reminder, I work predominantly in the field of transplantation, and for instance, in the hematopoietic stem cell transplant population, infectious complications are very, very common. So a stark reminder that 93% of allo transplants will undergo an infectious complication, a lot of which are bacteremia, but also 75% of recipients will also get CMV viral reactivation or infection. And this contributes significantly to the morbidity, not only through direct tissue invasive disease and obvious things such as colitis or pneumonitis, but a lot of indirect effects such as treatment-associated toxicities, which I'll go more into, and some of the indirect effects, and also just using up all our health resources. So when I talk about CMV disease and all our prevention strategies, they were initially, the initial aim of all the prevention strategies were really to prevent CMV disease. And CMV disease is like the end stage, very obvious. This is what we see in the hospital setting, and it causes really significant morbidity. So up here, I've got a slice of CT chest looking at CMV pneumonitis, and a colonoscopy picture looking at CMV colitis. Certainly in the stem cell transplant group, colitis has now become the much more predominant organ which CMV disease occurs, but also it does affect the lung and more rarely the CNS disease. And let's not forget that CMV pneumonitis still carries a very high mortality of around 85%. And although less common nowadays, this mortality remains really high despite all our best supportive care. Conditions or end organ disease such as CMV retinitis cause a lot of high morbidity. We have to achieve high antiviral concentrations, and these patients are on antivirals for a long time, and with that associated toxicities. Fortunately, our preventative strategies over the last decade or so have resulted in a much reduced level of CMV disease from what we would see prior to ganciclovir in the orders of the sort of 25 to 30%. We're now in the range of 3 to sort of 10%. But there are certain populations where in the transplant field where CMV disease is still quite significant, and in particular lung transplant and primary infection, where rates are around 22%. So I've discussed CMV disease, which is obvious end organ disease, but what about CMV viremia? Particularly asymptomatic CMV viremia. Is this a driver or passenger for bad outcomes for our transplant recipients? It's been made clear with the literature over time that we should not undervalue asymptomatic CMV viremia, and that it's been associated with lots of large transplant cohort registries and studies, that it's associated with increased all-cause mortality, but less so with infection-related mortality. So over here, I have a plot and a graph of study by Green et al., which really was one of the first studies to show that viremia, as low as 250 international units per mil, or any positive viremia, leads to increased risk of overall mortality, whether that be any level up to 1,000 in the early period post-transplant or up to day 365. And replicating or backing this up are large registries which look at if you're a CMV recipient positive, if you're recipient positive, that you have worse survival overall and increased transplant-related mortality related to CMV recipient positive versus your recipient negative, donor negative transplants. But most studies have been retrospective, although large, and we haven't had really any prospective studies to show this. And the question always asked is, should we be preventing asymptomatic CMV viremia? So just as an example, these are some survival plots that when we look just solely at CMV viremia itself, that there is no difference in overall survival. But when you look at CMV, in addition to other complications such as acute graft versus host disease, that we start to see those survival curves diverge with reduced survival over time. So back to the question of should we be preventing asymptomatic CMV viremia? Yes, in that it has, as I've shown, caused problems with non-relapse mortality and overall cause mortality. But what level CMV is significant, and when should I start or commence antivirals? And this is one of the most common questions I get asked. And overall, just to introduce this concept of clinically significant CMV infection, I think with different hospitals and different transplant centres using different machines or assays, it is difficult to try and standardise our viral loads overall. So there is a shift away from quantitating that and being exact with the CMV viral load to looking at the viral load together with other different risk factors. So according to the ASTCT guidelines on prevention, which were published back in 2021, the question came was, when should we start CMV treatments? Well, there's no validated universal threshold, and it was noted that it does vary by institute and also by patient risk. But in order to prevent disease falling into the low risk category, we think about generally a viral load in the order of 280 up to 900 international units per mil. But if you've got a very high risk patient, that you can go as low as 137, or some institutes use even any detectable level. So here at the NCIC, I've tried to categorize or sort of look at a higher risk stratification rather than just using recipient or donor serology. So this is just a large Australian study that was performed here across many states here of over 871 patients, which aim to better define risk. And we looked at recipient positive, donor positive, in addition, if they also had T cell depletion, unrelated donor or haploidentical transplants. And we compared this to low risk recipients, which was really anyone who was negative or a very closely matched donor with R plus D plus. And what we found, not surprisingly, was that this is a group who has a high burden of clinically significant CMV infection. So this high risk group, 54% versus 18% in the lower risk group. But not only that, but it did translate into greater lengths of stay in this patient, 39 days versus 31 days. It also led to increased frequency of readmissions and worse all-cause mortality. So these patients had a mortality of 32% versus low-risk CMV with a mortality of 24%. And this is on the back of understanding the burden that this disease has on our hospital system, admissions and length of stay, because not only in making a justification for better antivirals, we need to show that it is cost effective or achieving what we want, which is to keep patients safe and well and out of hospital. So this was a single centre study looking at 255 patients, which overall showed more frequent admissions if patients had clinically significant CMV in the first year after transplant, that these patients were spending up to a month longer overall. Total length of stay was higher in the first 12 months. And whilst we kind of think of CMV, most of it's managed outpatients and hopefully with just oral medications such as valganciclovir in this study at 39%. In fact, most of the patients had a combination of Valgan and intravenous ganciclovir or Valgan, intravenous ganciclovir and foscarnet. And ganciclovir and foscarnet, they need to be delivered intravenously and in a hospital setting. So in fact, a lot of these patients are spending time in the hospital getting their CMV treatment. And this translates to a burden on our hospital cost and resourcing. And this is a column graph to show overall costs in terms of in the little buckets of total hospitalisation, nursing, ICU, pharmacy, blood product costs across all different categories. Patients who had clinically significant CMV were using up more of these resources rather than no clinically significant CMV. So let's change tack now to CMV antivirals. So for many, many years, we've been using these drugs on the left-hand side here, the ganciclovir, valganciclovir, foscarnet and cidofovir. But on the right-hand side here, we have these new kids on the block. So drugs such as maribavir and letermovir, which I'll go more into now. And where have they found a place? So in the prevention space, letermovir is very good, and I'll show you some data. And in the treatment space, maribavir. So moving on to letermovir. So this is a novel anti-CMV drug, which binds specifically to CMV terminase complex rather than the polymerase, interrupting the late stage of CMV viral replication. And the advantages of letermovir is that it's very specific to CMV virus. So it won't cover your other herpes type viruses, and it has minimal toxicity. And its use was really cemented in this pivotal study published in the New England Journal, looking back a number of years ago, so 5 years ago now, where they looked at letermovir prophylaxis in patients before the onset of CMV viremia. And the primary endpoint, they used it for the first 100 days or first 14 weeks, and the primary endpoint was found to be significant. So letermovir rates, cumulative rates of CMV infection were much lower in the letermovir group at 37.5% versus placebo, which was an investigator-assigned treatment of what they were using at that institute at the time. And that was, as we expect, in the order of 60.6%. And so this was highly significant. But a great thing about this study was some of the other findings we found, which weren't a primary analysis, but they did find that at week 24, overall death or mortality was lower in the letermovir group at 10.2% versus 15.9%. And this mortality date wasn't statistically significant when we stretched it out to week 48, but neither did they cross over either, and it remained at least numerically different. So this was one of the first prospective studies to potentially associate a good antiviral treatment with better outcomes in terms of mortality. So what's happened since that time? Well, letermovir has been adopted pretty much globally. However, not so accessible or intermittent accessibility here in Australia. It's not yet subsidised or funded outside the hospital system. So letermovir is now being prescribed as a primary prophylaxis in a lot of parts of the US, Europe, and parts of Asia. And so a systematic review and meta-analysis was done looking at over 48 studies which have used letermovir now in over 7,000 patients. And the results and findings are really quite compelling and clear that letermovir prophylaxis lowers CMV reactivation, reduces those who require clinically significant CMV infection, lowers rates of CMV disease, and also lowers all-cause mortality and significantly lowers non-relapse mortality. So overall, this meta-analysis showed very effective at reducing CMV morbidity and mortality. So I haven't known in this space for a long time such significant findings from an antiviral. So what does one do when letermovir is found to be so good in the first 100 days? They ask the question, well, can we extend it and can we go to 200 days? So this is sort of hot off the press findings that were presented at EBMT just in April of this year in Paris, France, looking at a phase 3 randomized study of those patients who had 100 days of letermovir, and then they got randomized to continue to 200 days or not. And they wanted to look at efficacy beyond that first 100 days. And on the right-hand table here, I've got a list of what they deemed or classified to be high-risk CMV. And that's really the T-cell depleted grafts, the umbilical grafts or mismatch, and those who develop graft versus host disease requiring systemic prednisolone, which we see not infrequently. And this was a result, very interesting results, which I'll take a bit of time to go through. So this was on the x-axis, we've got the date week 14. So patients were on letermovir during this time out to week 48, which was their primary timing or the endpoint. And on the graph here, we've got the cumulative risk of CMV and infection over time. So in the dark green line here on the bottom, we have those who receive letermovir for the 200 days. And as you can see by that sort of flat line out to week 28, very minimal clinically significant CMV infection compared to the placebo, which these patients just stopped their letermovir. But after week 28, the rates bounce basically once you stop prophylaxis. And you can see here this sharp incline from week 28 to week 38, so that by week 48, there was no statistically significant rates between letermovir and placebo. So overall, this goes to show that perhaps the 100 days does have some outcomes and good outcomes and does show significance, but when you extend it out to 200 days, it's not very durable. And once you stop your prophylaxis, you get a rebound. So what's happening with letermovir in the solid organ transplant space? And this is again hot off the press, published online 2 days ago by Ajit and their team, looking at letermovir versus valganciclovir for prevention or prophylaxis of CMV in high-risk kidney transplant recipients. And this was an RCT. So they want to ask the question of whether letermovir was just as good as Valgan or non-inferior in prevention of CMV disease in this really high-risk group. And what I mean by high-risk group is CMV seronegative transplant getting a positive donor. So this was a very large study of 94 hospitals worldwide were involved, and they randomized 601 patients, of which 586 patients were analysed. 301 of whom received letermovir as well as the acyclovir, and 300 who received valganciclovir. And the primary outcome was CMV disease through week 52 after transplant. And their findings were that they showed non-inferiority. So letermovir rates of CMV disease in the letermovir group was 10.4% versus current standard or the comparator valganciclovir of 11.8%. And so a negative 1.4% difference, which makes the non-inferiority. So it's just as good, but what was more interesting, which was that it was much better tolerated. And we're always striving to not only get better drugs, but also better tolerable drugs. So in the letermovir group, rates of neutropenia were 2.7% versus 16.5% in the Valgan, and this translated to less use of G-CSF to support the neutrophils of 1.7 versus 7%. And a lot less people had to cease their intervention or the antivirals due to an adverse event in the letermovir group versus Valgan. So this study will be is very interesting, and that in the high-risk group, we have a better tolerated drug in letermovir for prevention of CMV disease. So moving on to treatments. So before letermovir use in prophylaxis or prevention, now I'm just going to discuss a little bit about treatments and maribavir, and particularly in the area of refractory and resistant CMV. So we're all fearful of resistant CMV, and how common is this? Well, some studies report up to 14% in the haploallotransplant group, which is quite a lot. And in the renal transplant group more recently, rates of mutations can be seen in up to 10%. And there's further work to be found in teasing that out. So typically CMV resistance occurs in the setting of having previous exposure to these antivirals, and often occur 2 to 4 months down the track in the setting of not only risk factors of haploidentical or T-cell depleted transplant, but also prolonged exposure when you've got low-level viremia. We may think that, low level of viral loads of 80 or 50 or low are not, have no adverse event, but over time, and if patients have subtherapeutic exposure to antivirals, whether that's due to non-adherence or poor absorption or dose interruption for other reasons, that these are increasing cumulative risk factors for resistance. And not surprisingly, having resistant or refractory CMV is associated with worse outcomes. So maribavir is one of the other new antivirals around, and it has found this study, phase 3 randomized clinical trial, looked at maribavir for resistant or refractory CMV infections in the transplant field. So maribavir is a new benzimidazole riboside, which is now FDA approved, and it interrupts viral replication, encapsulation, targets the viral capsid, and inhibits UL97. So this large study of called the Solstice study of 352 patients, assigned patients to either maribavir or investigator-assigned treatment. And the primary endpoint of CMV clearance was achieved with 55.9% achieving clearance at 8 weeks versus 20.8% with investigator assigned treatment. Now these primary endpoint clearance percentages don't seem a lot, but this is very highly complex multi-organ failure, usually a lot of complexity in these transplants by the time they have resistant refractory illness. Again, one of the advantages of maribavir is that because it's really CMV specific, that it may not have as much toxicity. And this was borne out with lower rates of neutropenia, 9.4% versus 33.9%, and also lower rates of renal impairment when with maribavir compared to what would have been given, which is foscarnet, with rates of 21.3%. Important to note, and with a bit of warning, that however that maribavir does not adequately penetrate the central nervous system, and that it's not recommended for use in encephalitis or retinitis. Maribavir has also been evaluated as preemptive therapy in the Aurora study, and this is a phase 3 randomized 1-to-1 double-blind study comparing maribavir to valganciclovir, looking at first asymptomatic level of CMV viremia greater than 910. And again, trying to find a space given that it has advantages of less neutropenia. And the primary endpoint, again, in this study was CMV clearance at week 8. However, unfortunately, at week 8, and this is in press release only, it hasn't been published, week 8, the drug did not achieve non-inferiority, with maribavir achieving a primary endpoint at 69.6% of patients versus Valgan at 77.4%. Treatment-related neutropenia was much less reduced in maribavir, and early discontinuation was reduced. However, it was not as efficacious as Valgan. And not only that, and more data to come out, but there is also a signal of emergent resistant mutations being detected. So what I take from this study, really interesting study, is that Valgan actually did very well, and more data is yet to be teased about sort of starting loads of viral loads, and more work needs to be done about this early signal of resistant mutations, which can be a bit worrying. So a proposal of how to use maribavir in this current stage is, well, if you have resistant genotypic confirmed CMV, that maribavir is quite useful in this setting. However, if you have refractory CMV with very high viral loads, it is recommended, or a guide, that we should bring that viral load down firstly with something like foscarnet, something that we know of, before instituting maribavir. And that is just this concern about emergent mutations. Moving on to some newer future-gazing therapies in the space of CMV is the use of viral-specific T-cell therapy. And by this, I mean infusing into transplant recipients specific T-cells which have been selected out and been stimulated against not only CMV, but we can do this against EBV and adenovirus. And this has been assessed in several different indications in the setting of prevention, and also therapeutic uses with persistent viremia, resistant CMV virus, and also with very severe CMV disease. And the way these can be manufactured is either donor-derived or third-party donor cells, and having a library or bank of cells, so that when we have a patient, we just don't have the time to manufacture the cells, and we can just reach into a library. And it's been a growing area of interest. And I'll show you some of the data here with a Australian study led by Barb Withers and Dave Gottlieb, looking at third-party multiviral CTLs in a really difficult group with use of T-cell depleted grafts. And these patients here, there was 28 with difficult CMV, EBV, and no virus. And they showed overall response using these cells to be around 93% at 12 months, which is quite remarkable. So where we go from this is that we really need to demonstrate randomized studies in this field to see what the place of T cell therapy is. And it is acknowledged that not all centres will have the facilities to deliver this at this stage, but randomized studies are needed. And there is one ongoing at the moment, a phase 2/3 multiviral T cell therapy, which is randomized with a placebo and blinded, looking at not only CMV, but EBV, BKV, and no virus, HHV6 and JC virus. So watch this space. So you might be there thinking, well, that's great. There's all these new drugs on the horizon, but I don't have access to those, or T cell therapies, and we don't have access to that. So you might be thinking, what can we do now at our institute to try and improve CMV outcomes? And I propose an antiviral stewardship program, or what we should do is use our current drugs better. And there are some antiviral stewardship programs around, but not so much for CMV, with only 2 studies led in the solid organ transplant group looking at CMV, and they can be pharmacy-led or multidisciplinary-led. So I'm just going to talk to you about what we do at my current institute here at Royal Melbourne and Peter Mac. So we have identified a lot of different problems or things that we thought we could address by instituting a program. So one of the first things was the communication of results and availability of viral load results. And before we looked at an antiviral stewardship results, we wouldn't know when results were happening. Public holidays were going. We were trying to plan admissions depending on when the results were coming through. We have a growing high-risk population of CMV, such as a haploidentical transplants. It did come, the other problem which was identified was really quite difficult CMV resistance cases. And we had a number of upcoming clinical studies where we thought it was worthwhile identifying these patients early. So we commenced a weekly dedicated CMV meeting, which was initially face-to-face and now works really well on Zoom, of which, we have like sometimes 40 up to 50 attendees. And we sort of integrate it into one of the other BMT planning meetings, and it's attended really well by all transplant physicians, not almost all, as well as nurse practitioners, ID physicians, registrars and pharmacists, and even transfusion staff. And we look at each successive transplant that we've done, and we review all their CMV viral loads, including those which have been missing, which is really important. And where we can sometimes fall down is the patients who are in another ward who haven't had their viral load, or forgot to turn up to clinic and we haven't had their viral load in a couple of weeks. So we follow those up. We discuss concurrent immunosuppression. So things such as, well, I'm about to start 1 milligram per kilo of prednisolone for GVHD. We can anticipate that the CMV viral load will go up. Or on the other hand, someone with low-level viremia, the BMT physician will say, well, I'm withdrawing prednisolone, so let's just watch and wait in that scenario. We review individual risk category. We agree upon a certain threshold for treatment, and we also agree on the choice of antivirals, such as oral or intravenous organciclovir and foscarnet. And overall, this has led to really improved communication between not only specialties, but also craft groups, and also just flow of patients with nursing and pharmacy and medical understanding who might be heading for an admission for foscarnet, or who's having trouble with neutropenia or low platelets and needing sort of blood support in that setting. We've identified at-risk patients earlier, started antivirals a bit earlier, discussed neutropenia and how we manage that, identify research participants, and we've also in that CMV meeting now looking at sort of EBV viral loads or other difficult viruses. So segue onto that, as part of a stewardship program per se, looking at antivirals, we shouldn't ignore immune monitoring. The immunity and viral load are very much intimately entwined, and monitoring the immune system to CMV advances a personalised approach to infection with improved risk stratification. And at the end of the day, what we want is a test which will help us guide not only primary prophylaxis, but those patients who might actually spontaneously clear their virus or need to continue. So in this diagram or figure over here, I've got a graph which looks at a really heavy immunosuppressive period, and often patients are on antivirals at that time. But then after, say, for instance, day 100, patients do sort of fall into a low risk category and a high risk category. And I think really at the end of prophylaxis, these immune monitoring assays could really help us. And I often get asked, well, what immune assays are there and what can we use? And there are a multitude of different assays, but really the assay to be used is what's available and local and easy for you at your centre. And in Australia, we have a incline towards using quantiferon CMV because it was developed right here in Melbourne. So the quantiferon CMV, if you use quantiferon gold, is very much like the assay for assessing latent TB, in that the tubes are pre-filled with a mitogen, a negative control, and also lined with CMV antigens. So it's very simple. You take the blood, incubate it overnight, and a very quick ELISA the next day shows you whether you're reactive, non-reactive, or indeterminate. Some of these other tests, so ELISpot testing, tetramer, and intracellular kinase staining, are very much not in routine care, and I would say are very much a research opportunity at the moment. But just to let you know, in development, ICS there's been a drive towards trying to standardise that, and overseas, Viracor have a ICS sort of testing that they're evaluating and doing. Again, it's quite difficult and costly. You have to send it out, but we're making gains in this space. And just as an example of how we could potentially use it, this was a great randomized study looking at recipient positive kidney transplants, looking at the quantiferon CMV, and patients were randomized to be guided by the results of quantiferon CMV when taken at day 30, 45, 60, or 90. And if it was reactive, they were to stop their prophylaxis versus a fixed duration, which at this institute was a blanket 90 days and then stop. And what they found was that when you use quantiferon CMV, you could actually save 33 days of unnecessary antivirals. So 57 days of antivirals versus 90 days in the immune guided therapy, and also better sort of safety outcomes. Neutropenia incidence was a lot less. So this is an example of where we could potentially use immune guided therapy. But it's currently, as I said, a bit costly, not so available. We need to demonstrate sort of benefits and better understanding, and particularly in the stem cell transplants. And we have some researchers here and PhD students who are looking into this. So last several minutes looking at unmet needs of CMV treatment currently. So we really need therapies which are have much less neutrophil toxicity. And no matter how you look at it, whether it's universal prophylaxis, preemptive or resistant refractory, the common theme with the current treatments that we have is that it causes bone marrow toxicity. and we have neutropenia as well as thrombocytopenia and anemia. Neutropenia is sort of very detrimental in the stem cell transplant group. It leads to, it's very common, up to grade 3 neutropenia is found in up to half of those, requiring preemptive therapy, and a lot of them need GCS support. But in the solid organ transplant group as well, prophylaxis using Valgan, one of the older studies looking at prophylaxis up to day 200, neutropenia was found in 15% of that cohort, and with a decent amount of requiring GCSF to support that. And a recent systematic review showed that neutropenia overall was more common when you're using prevention or prophylaxis compared to preemptive therapy. We also need our current therapies to be less renal toxic, and particularly when we have our resistant refractory CMV patients who are already highly immunosuppressed and probably have a lot of other different organ impairments. So the last thing we need is renal impairment, which really occurs in up to 21.3% when you're thinking about phoscarnet, and perhaps that is a underestimate of the renal impairment it causes. It's particularly worrisome when you've got ganciclovir resistance, and with renal failure, again, rates of up to 51% from renal impairment, and this affects mortality in the stem cell group more than the solid organ transplant group. As we all know, renal impairment with antivirals is troublesome, resource intensive. We've always got to adjust the antivirals. We don't have great population PK levels or exposure to Valgan, and it needs constant regular monitoring of bloods, and hence the inpatient stay. Speaking of therapeutic drug monitoring with current antivirals, this area is sort of ripe for more research in our endeavour to optimise the current use of antivirals a bit better. We need to improve exposure to antivirals in order to reduce resistance. And perhaps the therapeutic drug levels are related to neutropenia, although current studies don't particularly show this. Current studies are very heterogeneous, and so we can't make any sort of real broad conclusions, particularly in the stem cell transplant population, of which very few have been included. So again, we have another PhD student, Suan Ho, who'll be looking at this with the future being to optimise what we currently have to conserve our antivirals in this form of a better use. A slide now just on what's happening with CMV vaccines. So several vaccines have been candidates in the past, and they've all sort of fallen over, but more recently an mRNA Moderna vaccine is currently available and addresses this sort of unmet need for prevention. And at the moment, it's this is just one of several different studies, but looking at CMV vaccines in a non-immune population, and this one's targeting healthy childbearing females under the age of 40 who are exposed to young children, and it's currently aims to enrol over 7,000 participants, and Australia is a site, and here at Royal Melbourne is a site, with the aim of looking at efficacy in this, first of all, non-immune population, then trying to translate that into an immune population. And where it would potentially be used is if a potential donor who was recipient negative or received a vaccine. So to conclude, I hope I've shown here that despite our gains in knowledge over the last couple of decades, that CMV and the transplant group remains really, really challenging, and there's more that we need to do to finesse and improve outcomes for our patients. I hope I've shown you some of the evolving concepts of what clinically significant CMV infection is, and how this relates to CMV, how this relates to non-relapse mortality. I hopefully have shown you some of the new antivirals which are on the horizon, how they may address the toxicities. I think there'll be a shift towards primary prophylaxis with our current medications in the stem cell transplant group, and that's happening globally. But also I think there might be a shift towards preemptive therapy in some of the low-risk solid organ transplant groups who won't need sort of 9 months fixed duration of antivirals. We need a better personalised approach, and perhaps immune monitoring will help with this. And also exciting in this field is the upcoming viral specific T cell therapies, and randomised studies are needed. So with that, I want to acknowledge my collaborators and all the research staff who have helped me at Peter Mac, the NCIC. I'm supported by some NHMRC and MRFF and my colleagues at Royal Melbourne Hospital, as well as internationally. Thank you so much.
Thank you, Michelle, for that fantastic run through of all things CMV. We have quite a few people online, and so if anyone would like to ask a question, please put up your hand. I might ask a quick question about the T cell therapy, Michelle. Do you see that becoming more streamlined and more available in the near future?
Yes, I'm hoping so. It is a very difficult thing to set up, and I think we'd have to speak to our transfusion colleagues in that you need to have the right resourcing, and it is very labour intensive, but the long-term outcomes are really quite good. So it gives a much more sustained approach to viral reactivations in that regard. So I hope and see and do envisage that it will become more mainstream in the future. I'm looking forward to results of a randomised study, however.
Thanks, Michelle. And Gab, I see you have your hand up. And then after that, Gab, there's someone who's on an iPhone. So Gab first.
Thank you. Thanks, Michelle. I love it. CMV talk from you. At the beginning, I might have missed it. I just jumped on about 5 minutes late, but you mentioned that colitis as a disease, end organ disease, has increasing frequency compared to other end organ diseases. Why is that? Because we really struggle with that in pediatrics, and obviously teasing it out between all the other reasons that can cause the colitis.
Well, what we're seeing is very much, so it used to be pneumonitis, and we, I must admit, I have very rarely seen it over the last year or so. Maybe due to compartmentalization of virus in the mucosa, and that we have this poor immune response in the mucosa, and then sort of takes off in the gut system. And it can be colitis, it can be esophagitis with terminal ileitis throughout all the GIT system. And an issue which I didn't touch upon here is that it's often not always corresponding to a viremia. So all the viruses in the mucosa, it's only through biopsy that we recognise it. And like you said, there's multiple different reasons for that biopsy. It is difficult to tease out, but certainly that's the changing epidemiology now.
Thank you.
And could the person on the iPhone who has a question with their hand up identify themselves and ask their question, please?
Yeah, hi, it's Tori. Sorry, I don't know why it came up as an iPhone. Yeah, thanks, Michelle. It's fantastic talk. I'm really interested in letermovir, especially with Ajit Lemay's recent publication, very exciting for SOT. And what you think about, whether this might improve the intermittent access in Australia, and if you think it will also translate into prophylaxis for the solid organ transplant population as well as stem cell transplant.
Yeah, thanks, Tori. You know this space as well as I do, that I do see this as an advancement and improvement, and particularly with the reduction in toxicity, that lutimavir, and the advantage of that over valganciclovir. So it's the next frontier, trying to get that into routine practice. It might be a very hard task in some countries or some institutes because it didn't show efficacy. And it may be hard to demonstrate cost benefit on toxicity alone, but that's exactly what we're trying to endeavour to do in the stem cell transplant population. And in that population, we have really good hard outcomes of non-relapse mortality, and that's also been difficult. But I do see this as being a practice-changing study. And it will be relevant to different parts. So some parts of the world see a lot of the this high risk group, and in talking to my Asia Pacific colleagues, some people don't really see that high risk group. So it'll be really interesting to see where it falls and who adopts it and which countries and long-term effects of this.
Michelle, I'm really interested in your antiviral stewardship program. You mentioned there's very little literature. Is there any about how it can demonstrate a benefit in patient outcomes?
Yeah, no, at the moment it's very, there's very few, little literature in this area, and really quite descriptive. There's better patient outcomes in terms of time to initiation of antivirals, but no sort of hard long-term outcomes such as mortality, for instance. But definitely days saved of antivirals they've demonstrated, and reduced neutropenia they've demonstrated. So I would really like to evaluate our current program. Again, hasn't been done in the stem cell group yet, and to look at some of these hard outcomes.
We've got two more questions. Thanks, Michelle. Jasmine Chung has her hand up.
Oh, hi. Thanks, Michelle and Jasmine from Singapore. Thanks for the talk. I was actually wondering about your experience with CMV immunomonitoring in the transplant population. We're thinking about introducing this test and monitoring into our program. But the question is which test and how do we monitor it, and how do we use it effectively in our program? I was wondering about your experience. Thank you.
Hi, Jasmine. Thank you for listening, and great question. I have sort of similar questions about what to do with a CMV monitoring program, what to use and how best to use it. So we've just done it in the stem cell group as part of a research setting at the moment, and I've evaluated a number of those immune assays, ELISpot, the quantiferon, as well as ICS, and it does seem to predict those who will have a complication. In the solid organ transplant group, it is good at predicting those if you're reactive at having no further complications and being able to stop antivirals. Where it can also help is if you found it's negative, and these are your high-risk patients, particularly if you've got like lung or high-risk lung or renal transplants. I don't have a quick answer. That's my experience. We're wanting to bring it in as routine care, and there's a study going on well, it's been used in the renal transplant setting at this stage. It's a little bit hit and miss at the moment. So maybe we can talk in a year's time and I'll have some more information for you.
Sure, thank you.
Thanks, Michelle. And Pedro, last question.
Yeah, I wanted to know, I know it has been hypothesized that the mechanism of action of letermovir and other antivirals is different, and I don't know if you have experience or if you can comment something on the combination therapy, especially in severe patients. And the other question I have is that I see that you are using a lot of these T cells, specific T cells in this population, but I don't know if there's a specific profile where you could recommend that especially.
Yeah, great. Thanks, Pedro. the question of combination therapy. So at this stage, it's not recommended in the setting of CMV, but of course, it is sometimes done in practice. And the reason it's not generally recommended is because of that cumulative effect of toxicity. And I'm not aware of any combinations with letermovir as well, which should only really be used in the setting of primary prophylaxis. The question of T-cell therapy is really interesting. Outside of a study, we've used it in about a dozen different patients, and those patients are the really, really tricky cases. So they can't tolerate Valgan, they've got low counts, they've got renal impairment, they've got multiple different viruses, or they keep recurring. Like, you know, you put them on antivirals, as soon as they come off 2 weeks later, you can predict that they're going to run into trouble again. And we've had some really good long-term outcomes in those patients, not only for CMV, but really difficult BK and EBV as well. But the typical profile is someone at the moment who's gone through the gamut of standard antivirals, got GVHD and sort of organ failure.
Okay, very quick question, Nick, if you can. Very quick, we're nearly on time.
Oh, thanks very much, Michelle. That's really interesting. Just a very quick one. I mean, I realise that as a new drug with letermovir, the cost may preclude this, but do you think that there's possibly a role in the future for extended CMV prophylaxis in those high-risk patients, you know, as we do with like Valtrex, Zoster, where immune monitoring isn't going to be possible, just because obviously it seems to be very effective, and then they relapse in a period where probably they haven't, you know, had any real immune reconstitution, particularly in the stem cell transplant patients.
Thanks, Nick. That's a really, really great question. So I suppose if taking away cost, it's a very effective antiviral agent. I do have some concerns about, as we've seen with other things such as Valtrex, if you don't take it properly and consistently and adhere to it, we do start to see resistance, and it's not as good at reducing resistance as, say, valganciclovir. So there's a lower barrier to mutations. So I do have some concerns about letermovir in that setting, and it's something to think about and should be thought of, because we certainly see patients up to a year who have just bounced around constantly with viremia, and so a really good secondary prophylaxis that's sustainable and well tolerated is required.
Thanks, Michelle. And I'd like to thank you for your excellent presentation today. And thanks to everyone who dialed in. Sorry about the mix up at the start, but we got here in the end and it was well worth it. So thanks again, Michelle, and thanks to everyone online.
Thank you.